So this, for me, is always one of the funner exercises that we do in PDS. We've considered lots of different aspects of the healthcare system in the past 4 days, and we sort of bring it to a conclusion with a discussion. I'm very happy to have the panel that is going to be assembled today. Bill Curry, you know. Max Michael, many of you met yesterday. For those of you who didn't meet him, he is the Dean of the School of Public Health and the former CEO of Cooper Green Hospital. And I'm very happy to have him here. Kathleen Bowen is a medical director for Blue Cross of Alabama. So that's a unique perspective that I'm very happy she can bring to us. Bill, you know, Stefan, you know, and finally Reagan Durant, a friend and colleague who in the Division of Preventive Medicine, who works especially on healthcare disparities and the relationship of minority communities to the healthcare system. Welcome, Reagan. So, our order of business is going to be initially a kind of point-counterpoint between Dr. Kertesz and myself. I'm going to present the ACA, a case for pessimism. Dr. Kertesz will present the ACA, a positive opinion. After that, what we'll do is we'll mostly probably interact among ourselves here on the panel for a while. But then in the second hour especially, we will bring you all into the discussion and invite your comments, thoughts, questions, and we'll have a good time. Stefan and I are going to try to be brief. So Stefan warned me toward the limits of what we think we want to do. So Dr. Curry talked about unintended consequences, and I think the ACA is a case where unintended consequences are going to be, unfortunately, very important. Let's start with a poll. So the ACA is a good idea. It's okay if it's a way station to single payer. It's okay if it's a way station to market-oriented reforms, or it's a bad idea. Timer has started. Okay, so actually a somewhat negative perception of the ACA on the whole, but actually probably a little more positive than last year. This was the same poll that last year's class answered, and so you guys are actually somewhat more positive toward it than they were, which is interesting because opinion in the country has actually become significantly more negative in the last year overall. Well, as Dr. Curry said, I mean, there really is this idea of a three-legged stool, all three legs of which are necessary for the ACA to work. I want to begin by talking about what the ACA is likely to do with employer-sponsored health insurance. The intentions, of course, are good. We're going to improve employer-sponsored health insurance by making the plans offered by employers meet higher actuarial standards, pay a higher proportion of a standard population's healthcare costs compared to what some plans, particularly among companies that have lots of low to moderate income employees, currently pay. And secondly, we're going to increase the prevalence of employer-sponsored health insurance by having a mandate to force employers to offer it. Now, how are those things going to work in practice? This is where the devil is in the details. And what the mandate says is that if you don't offer insurance, you're going to pay a penalty of $2,000 per worker. Now, if you compare that to the average cost of sort of good employer-sponsored health insurance, what you see is that there's a pretty big difference between the cost to the employer of paying for that compared to the cost to the employer of paying the penalty. So I think you need to ask yourself, what's the incentive for the employer given that discrepancy. And I'm going to sort of use my crystal ball here and project that what's going to happen is that big companies, I mean, it's clear that they're going to have an incentive to drop employer-sponsored health insurance. I think we can debate about how many of them are going to do that. Many people feel that a lot of them will. What about smaller companies offering low actuarial value plans, such as the Bronze Plan, which is the minimum that has to be offered under the ACA? That's a little more questionable, but I think if we look at some companies that have actually made public some of their thinking about this, what we see, for instance, the company that runs the restaurant TGI Fridays, they have 22,000 employees. Right now, they offer some high deductible HSA plans, and they offer some mini med plans, which are limited payout plans, not very good plans, many people would say. And about 20% of their employees enroll, consistent with what Dr. Kertesz said yesterday, and the company pays what it pays. What's going to happen when they have to update their plans to ACA standards? They can increase their costs a lot, or they can stop offering coverage and slightly lower their costs. Now, at this point, Carlson plans to continue to offer coverage. But once again, it's clear that the incentives are not in the right direction. So there are lots of estimates as to what's going to happen to employer-sponsored health insurance. The CBO initially projected that some companies would drop it, but not very many. Other estimates are much higher. Perhaps Douglas Holtz-Eakin would say, 22% of companies are going to drop it. McKinsey says that 30% of companies are going to drop it. My sense is that those larger numbers are probably more realistic. Employer-sponsored health insurance in this country may shrink precipitously once the ACA fully comes into play because of the incentives that it generates. But it's even worse than that. I mean, I think you can look at it from the standpoint of what employers are going to do, but also what are employees going to do? Once the ACA standard plans become mandatory, are low to moderate income employees going to take them up because the premiums are going to be more expensive. And this is simply an example. The CEO of CKE Enterprises, Carl's and Hardy Restaurants, what he projects is that the employee share is going to be $2,000 to $3,000 a year for the good policies, and at least $1,100 a year for the minimum policies that the lower paid employees would have a mandate to take up. Now look at it from the employee's point of view. The individual mandate says they have to have insurance. But how's that going to work? The individual mandate, if you're an individual, several years from now when the full penalty kicks in, the penalty is $700 a year. Now if you have decided as a young, invincible, healthy restaurant worker that you're not willing to pay that at this point, are you going to be more likely to pay it when the cost to you is going to be at least $1,100, whereas you could pay $700 and fulfill the individual mandate's penalty? But beyond that, you don't have to pay the individual mandate's penalty, because guess what enforcement is of the individual mandate? Zero. The IRS has been instructed not to enforce it. So another disincentive for lower income people to actually buy insurance. This is not looking good. So employer-sponsored health insurance, what I think we're going to see, fewer employers are going to offer it. There's going to be less policy take-up among lower paid employees. The employer sort of segment of the insurance industry is going to shrink, and all those people are going to the extent that they do buy insurance, they're going to, particularly in the case of employers that drop it, their employees are going to be pushed to the individual market. The individual market is going to expand, the realm of the insurance exchanges. Now, what's going to happen to the individual market? The insurance reforms, Dr. Curry mentioned them: guaranteed issue, community rating, Standardization of benefits at a higher level than the individual market now has, on average, and first dollar coverage for preventive care. Now, what's this going to do to premiums in the individual market? It's not going to do just bad things. It's going to raise premiums precipitously for people like you all, who are young and healthy. It's going to lower premiums for people that are sick. So that's a good effect. People that have pre-existing conditions, people that have high health care needs, they're going to be able to buy insurance, whereas before they couldn't. But the expense of that is that premiums for you guys are going to go through the roof, relatively speaking, 60 to 90% increases, depending on the state. So the individual market gets bigger, but there's less risk pooling because young, healthy people are going to participate less. On average, premiums are going to be much higher, except for those for pre-existing conditions. Fewer people are going to get insured. Finally, for the other thing that I haven't mentioned, is guaranteed issue. That young, healthy restaurant worker who doesn't make a lot of money, who doesn't want to pay that premium, is also going to say to him or herself, it's really not a problem, because if I get sick, I can buy insurance then. I don't need to be insured. I'm still safe. So in the individual market, I think there's a great danger that what we're going to see is this combination of individual, I should say guaranteed issue, community rating, a mandate that is not really a mandate. It's a toothless mandate. That's going to lead to churning of young, healthy people in and out of the market as they need insurance. And from what you remember about the economics of insurance, it should be clear to you that that's not a sustainable model for an insurance company to be able to stay in business. So I think there's a danger that in the individual market, insurance companies are going to be in a big bind. Medicare you've already heard about. Medicare rates are going to go down. Now, what's that going to mean? I don't think it's going to mean that ophthalmologists are going to stop participating in Medicare. An ophthalmologist can get $800+ for a 15-minute cataract procedure, and if that fee goes down, the ophthalmologist is still going to be willing to participate. Primary care doctor, who gets $58 for an average office visit, when that person's fees shrink, the primary care doctor is going to stop participating in Medicare. We already know that many primary care doctors are not willing to see new Medicare patients. What's increasingly going to happen is that primary care doctors are going to opt out of Medicare altogether. We're seeing that now with the rise of retainer medicine, cash practices. I think that's going to be the wave of the future under the current conditions as projected by this law. Medicaid, we're going to see continued budget strains. In the present situation, Medicaid is a parlous organization. Already states are having trouble paying for it. That's going to continue to be the case in spite of the generosity of the federal government with the Medicaid expansion. The larger economy is going to have less growth and less prosperity than it otherwise would because people are going to hire fewer people. Companies are not going to be willing to go above the threshold at which they have to buy insurance, and there's going to be a lot more part-time work compared to full-time work. This is not good in regard to how we're going to support and pay for the additional coverage that the ACA is going to provide. Finally, as Dr. Curry pointed out, the ACA really does nothing substantial to rein in cost inflation. Now, we've talked about cost and coverage as separate issues, but I would argue that they're not separate issues in the long run. If cost is not reined in, and if the government eventually starts to go broke, and we can't support our obligations, there's going to be a lot of people who are not going to get the care that they need. So controlling costs is as much a humanitarian imperative as it is a fiscal imperative. If we don't do that, we're not going to be able to take care of the people that we need to be able to take care of, and the ACA does nothing to alter the trajectory that we're on towards fiscal insolvency. So, if we strike a balance sheet, which I'll do very quickly, lots of positives in regard to coverage. Lots of negatives, however, in my view, including the possible destruction of the individual market for insurance, an access crisis at the level of primary care, and no fundamental reforms of healthcare cost inflation. I think single payer would be better than this, and I'm not a person of the left. I think we should go one way or the other. We should have market-oriented reforms that actually make the market work, or we should bite the bullet and go to single payer, have a global budget. This sort of falls in between and is going to leave us with the worst of all possible worlds.
Okay, we got to swap slides. Thank you, Tom. Okay, so this is going to be a positive opinion. And as I start, I'll disclaim I work for the federal government. This certainly doesn't represent a particular position of the federal government. Let me stipulate up front that I would be okay with a variety of different changes to the healthcare system that have been discussed, including differences in the ways people purchase private insurance or single payer, which is probably where my bias really was. However, what I'm going to make the case here today is that I'm profoundly not okay with delaying the expansion of coverage until somebody else can acquire the political power in the current system to come up with that ideal system. I'm not one who says, yeah, another 15 years down the line, we'll do something much better than this crappy Obamacare, and that'll be a far better solution than what's happened. And I'm going to make the presentation to you that we can afford the coverage expansions of the Affordable Care Act. I'm going to skip that one. So what does one endorse in taking a positive view of the Affordable Care Act now? And what I would say is you endorse three things if you decide to assume that view. One, we want to reduce suffering. Now, not 5 years from now, 10 years from now. Two, you have to address political realities. The law that you pass has to be one that is passable in the politics of the United States of America as it is today. Not the United States of the Heritage Foundation, and not the United States of the Urban Institute, the United States of America. Three, you have to devise tolerable costs for the expansion. And I think that one endorses the Affordable Care Act because all three are, in fact, appropriate premises. Overview of the Affordable Care Act actually was very well provided by Dr. Curry. I don't think that this slide really changes what Tom and Dr. Curry have said. Just note the bottom line, experimental provisions to bend the cost curve. And you're not going to hear from me that there's a guaranteed bending of the overall path of expenditure for American health care as a result of the Affordable Care Act. You're going to hear from me that we don't know how to do it, and there's some little experiments at it, and that's all I'm going to say about that. The insurance effects, this is a slide I showed you before from the Congressional Budget Office. A bunch of people get insurance. By no means do all people get insurance. The cost curve efforts, this is one slide on this. The accountable care organizations is an issue that merits study. These are typically networks of physicians and providers who engage both in taking on financial reward, shared risk, and systematic quality improvement. There's mixed information. I mean, there's organizations that started doing this. There's some promising data. It's not clear that these are going to be a massive cost-saving enterprise, although they've saved some. There are Medicare provisions to target reductions in payments to hospitals. Tom showed you a very dire-looking slide. And we won't talk about that at length, but clearly there's a desire to slow the rate of Medicare growth built into the law. There's this advisory board that has to adjust Medicare rates by year if targets are not met, and there's these taxes on Cadillac plans. What can we expect? A bumpy rollout. The next few years are not going to make this law look pretty. The health exchanges are going to have several challenges. They have to enroll people who are poor and not currently in a federal benefits program. When I looked back on the enrollment in the Children's Health Insurance Program, which is an expansion of Medicaid, the truth is the percentage of kids enrolled rose year by year over 10 years. going out and finding poor families who are disconnected from benefits and getting people in is like a long-term campaign. It has to occur amidst political opposition. So far, 18 states have said they will set up their own exchanges, but that means the federal government has to create an exchange to serve many more states and people than it had originally planned, and it's behind on doing that. Public marketing, enrollment, helping people navigate and get connected to these systems are crucial, and they are delayed. So initial sign-up will be low, especially in the states that haven't planned to assist that. Now, states that have, like New York and California, if they take the Massachusetts approach where you get the football team and the baseball team and people going public advertising, more will happen. Political challenges. This is a picture of somebody burning their Obamacare registration certificate. It's a new campaign from FreedomWorks. There are grassroots campaigns to encourage young adults not to sign up. Some states are declining to support or indicating they will not enforce any insurance reforms. Those include Texas and Alabama. And there will be congressional showdowns. So it's going to be rocky. And if it fails, it will be because the politics still weren't right. The politics of America still weren't right for either single payer or for more market-oriented or for this. There's a lot of heat. And let's talk about this recent flurry of heat. As Dr. Huddle suggested, there's going to be this big, giant skyrocket in rates in the independent market. Cheapest Obamacare premiums cost twice as much as existing plans. So the truth about that is a little bit more nuanced. Affordable Care Act causes some change because it doesn't allow young adults to pay as much less as they currently can. It has a ratio of 3-to-1 from youngest to oldest as opposed to 5-to-1. Most young adults are not likely to be terribly affected by this because the ones who are really poor are going to get Medicaid in the states that expand, which is still most states. They will get credits to buy insurance from the Affordable Care Act. The slide Tom showed you specifically excluded any consideration of the assistance you receive in buying it. And many young adults who make, the kind of person who would not get any help from the Affordable Care Act, who's making, $70,000 a year, is often in a job that has insurance. 92% of adults aged 21 to 27 have an income less than 300% of federal poverty. So these are those young adults, those young invincibles, are actually all eligible for assistance in buying health care on the exchanges. So what about a plan on the exchange versus the private non-group insurance market as it exists today? The market that you now hear people saying, my gosh, the rates are going to skyrocket. It's terrible that we're losing access to this private non-group market with its great rates. So it's premiums without considering the assistance will rise for some young adults and fall for others. When you see the attacks, it's always the lowest cost plan in the region compared to what's on the premiums for that state. These comparisons neglect and fail to mention the things that make them non-comparable. First, they neglect the fact that 10 to 20% of people seeking to purchase the insurance are denied. That's a different thing. They neglect the extremely high out-of-pocket costs built into those plans. They neglect the restricted or completely absent mental health and maternity care. And I spent a long time looking up at maternity care issues. 90% of these plans don't offer maternity. And the maternity rider is $200 to $500 a month for coverage that may not even cover the cost of having your baby. I read a story about a very intelligent woman. She's an article writer for some news magazine. The first time she didn't realize she didn't have maternity coverage, so she bought it the second baby. It only covered $3,000 out of her $11,000 bill. She felt fooled twice. And what really they don't get at is the bewildering complexity of the plans that are sold on the individual non-group market. There are 10 to 20 variables manipulated to make plans look good, and they do not tell you easily what you're not going to be getting. No surprise, they often offer low protection. Just recently, in an exercise with another physician, two of us could not readily agree, looking at esurance.com, we could not readily agree on whether the same plan had $10,000 or $5,000 of out-of-pocket expense, or whether it had maternity coverage. Two trained doctors couldn't figure out what was offered. How good is this market? So my view of the private individual non-group market for health insurance, whose rates are going to increase, is that it's bewildering complexity, penalties for being female, lousy protection, time to say goodbye. Now, you did hear a claim about part-time growth incentives because the employer mandate. I just want to point out that when you look at larger databases that assess employment growth over time, part-time and full-time, the growth in part-time jobs over 14 years is the blue line. The growth in full-time jobs over 14 years is the red line. sorry, my bracket movement. It's the tiny little bump in part-time jobs in the last 6 months that's really not much higher than any of the other bumps since the big downturn in the economy. It's the ratio that is leading to that discussion. And essentially, people are taking very volatile data using a smaller database than this one to result in the claim, which I disagree. Fundamentally, I think that there's been a little bit of hype on something that is more complicated. It may not be good to have an employer mandate, but it's not that there's suddenly been a booming part-time hiring thing that is separate from what we have generally going on in the economy over the last 4 years. Can we afford it? American healthcare represents a semi-stable situation that is long-term unsustainable. I completely agree with Dr. Curry and Dr. Huddle on that. Its current semi-stability depends on economic growth and the U.S. ability to borrow money at low rates. We have a long-term problem. Covering 30 million uninsured people is morally compelling and modestly financially, in my view, and I'm going to show you the numbers. What are the net costs of covering people in the Affordable Care Act? This is a graph. Red shows expenses as of 2023, in an out year from the Congressional Budget Office. $98 billion will be going on Medicaid and CHIP. $151 billion will be going on exchange subsidies and related costs. $2 billion on some small employer tax credits. There's some provisions built into the law to bring in some taxes. $6 billion on penalty payments from the employers. $20 billion on excise taxes on, I'm sorry, I got it a little off. Yeah, uninsured might pay some penalty. The employers will pay $20 billion in penalties, excise tax on Cadillac plans, other effects on revenue and outlays. So the net, if this does not, I'm not assuming a single dollar of savings from slowing the rate of growth of Medicare. Set it aside. It's very speculative. I agree with Dr. Curry. So the net is we got to find $170 billion in the year 2023 to insure those people in 2023. How big is $170 billion? What can't we afford? Here's $171 billion, sorry, compared to the effect in 2021 of extending the Bush tax cuts on December 31st, $521 billion. There was not a real concern about our inability to afford the $521 billion of money that the government will not collect in 2021 for those Bush tax cuts, but we are absolutely sure we cannot possibly deal with the $171 billion of cost in 2023 to cover 20 million or 30 million uninsured people. Again, the cost of our system is gargantuan. Its growth is a real problem. Dr. Curry and Dr. Huddle are right. The total projected spending in 2023 is $5.3 trillion. The total projected federal expenditure in 2023 is $1.76 trillion. We can't afford it. I agree. We can't afford that, the two lines on the right. The $0.17 trillion that represents our investment to cover the 30 million is, to me, morally compelling. In the end, it comes down to a metaphor. I drew this and did not have to pay myself for this drawing. Here is the USS Healthcare. It's labeled from last year, $2.4 trillion ship currently, but that's not an accurate representation. It's a ship with a hole in the bottom with water coming in. And it's semi-stable, as I said, because the U.S. is not going down. We're not Detroit. We pump out the water by a mixture of tax collections, taxes on current workers, and the fact that we currently still borrow money. And if you are in such a stable situation, you face some moral choices. For instance, your ship might go by a bunch of people in the water with a tidal wave coming at them who are not covered, with vultures flying overhead. And you have to make a moral choice. Consider which one of these you agree with. One is, we're not really stable here. We'll head back to port, get patched up, and pick you up a year or 4 from now. Love ya. B, get on board. It's not much extra weight, and we're going to have to figure out our problems as we go along anyway. C, gee, maybe we should have picked you up 10 years ago, but if we take you now, we'll sink. And I think that the decision about whether you can afford the $0.17 trillion in a $5.3 trillion system in 2023 comes down to your moral disposition on that metaphor. Now, Tom, do you want to make your comment that you made about this the last time? I will for you if you don't. Tom's retort is, no, no, no. This isn't about people outside a boat with a hole in it. It's Stefan Kertesz wants to steer that boat at maximum speed toward an iceberg. Thank you.